Ladies and gentlemen, dear colleagues, dear friends, dear students, thank you very much for tuning in. I choose the topic on the entanglement of overdose, self-harming behavior, and suicide due to the development in the last 2 years, where the number of fatalities among adolescents and young adults increased very significantly, and especially in the age of young adulthood between 19 and 29, tenfold. For me, the treatment and handling of youth mental health is an indicator for the overall functioning of a healthcare system. And North America is not providing a very good picture. Unfortunately, only 10% of those kids who survived an overdose in the US, less than 10% were getting into any kind of appropriate care. The substitution treatment is still an exception, and good psychosocial care, regardless of the treatment goals, is nearly not accessible or it's extremely expensive. So I wanted to try to paint a picture, and the reasons I will explain in a bit. I'm the UBC Leadership Chair for Addiction Research, and I have funding from the Canadian Institute of Health Research, Health Canada, and others. And I'm working as an advisor for significant global organizations. And as well, I'm running a startup company on traditional medicine and substance use care. So there are 3 objectives I want to address in my presentation. One is discussing the entanglement of high-risk substance use and concurrent mental disorders, especially, to try to sketch the synergy of self-harm, suicidality, and overdose towards an increased risk of mortality, and share some ideas about functional care and a system, a clinical trajectory of effective interventions. Okay, if you look at this graph, you see in the last 10 years, the increase in mortality in the age group between especially 19 and 29. Also before, so under 18, we have to register an increase in mortality, but especially in young adulthood or in transitional youth, the increase is dramatic and needs our immediate attention. So what are the risks? What is behind this development? In order to understand overdose and understand substance use in general, it is important to develop a model for the process and the model of disease, as well as a model of care. Only if we understand the functionality of self-harming behavior and destructive behavior overall, we may be able to respond to it effectively and provide care the clients can accept and benefit from. Therapeutic interventions compete in their functionalities with the logic of risk-taking, self-medication, and self-harm. So it is not just a biological deficit or a genetic disposition, or if at all, it is a complex psychological and emotional effect which users try to use to balance themselves. A lot of my patients always tell me they're not feeling really much better or great. They just feeling normal if they're using. And this normality keeps them going, is highly motivating for them. So unfortunately, between the different providers in the healthcare system and also patients and so-called experts, there is not a good agreement, or they're not sharing the same perspective. So you could also say it's incompatible what different people right now is promoting and thinking, which makes the message and the treatment direction and the overall functioning of the system extremely confusing and ineffective. Some see substance use as recreational. Some professionals really don't like to be involved in the care of patients with complex concurrent disorders or substance use at all. And some addiction providers, especially also a lot of colleagues in the field of O treatment, are not really convinced that counseling and psychosocial interventions of any kind are necessary at all, which is especially also contributing to the major effort now of so-called safe supply, where programs are distributing high-potent opiates like hydromorphone and other medications among heavy drug users. So far, over the last 3 years, with not a lot of success. The numbers in 2022 and 21 before are mind-boggling. 6 people per day in British Columbia alone are dying of an opiate overdose. So different perspectives have different consequences. So if you think that behavior is recreational, then the consequence would be clearly legalization and not really including it into any healthcare system concerns or legal measures. If it is self-medication and if it is an attempt to deal with your own emotional or physical balance and problems, then it is clearly different. Then you need to build better treatment systems and more effective interventions to deal with pain, to deal with emotional pain, to deal with suicidality and all these concurrent conditions. So it's all about understanding high-risk substance use, and the understanding in our society is very different. There's a variety of perspectives, and it's mainly driven by biological models. The fact that a lot of the users and also those who are taking high risks and heavy users, that they are trying to reduce their emotional and physical suffering, that they want to be accepted in their peer groups and trying to leave and flee traumatizing environment or families which are not really supportive is neglected, and the support, care, and treatment needs need to be understood. The reasons need to be specified in order to be able to address them in a different way, in a less harmful way, and help them to recover from these experiences. So this is a little summary slide. If you look at the current evidence about high-risk substance users, 15-20% of overdose attempts have indications for a suicide attempt. There is a lot of literature about that, and it's all about this kind of range of attempts. Then in a big study I did in Germany, there were 54% of the injection drug users in contact to the system of care reported suicide attempts. And they also reported in an impressively high level chronic pain. 2/3 reported early traumatic experience, and the first injection of opiates was always related to psychological distress. So self-harm, complex traumatic experience, suicidality are all very close to high-risk substance use and overdose risk, and are connected and need to be seen together. If you want to build a more effective system of care, you need to address those background factors which coming with it, and not splitting the system of care and creating more silos. So going into the details. So trauma and overdose could be a catalyst. Trauma is reported, as I said, by the majority of users, and trauma treatment in the framework of substance use care is nearly not provided. It turns out that very often self-medication with high potent drugs is the only accessible option to address emotional and physical pain. So that's even also especially true for First Nation kids. And I would show you an example here. This is the most discussed case story in British Columbia. It's about Paige, a young woman who had to go through 19 different foster families, and that on the background of her mother and her grandmother dying from an overdose. So obviously the welfare system was unable to identify appropriate care or didn't care. And the end was that Paige also overdosed herself in a public washroom. This is a story well described, and I recommend to study it and to learn from it, because it is a disgrace for all of us. Addiction is that way a very human process. Psychotropic substances beyond opiates are a regulator of psychological states. Their use is cultivated and used across generation, also as part of the family history. It's extremely interesting to look what happened before without blaming anybody. It's more the question, how can we, as part of the healthcare system, help families and users and all of people involved to manage their situation, their risks in a better way. Management of risk and treatment needs could create a correctional experience, are the only way to recover from that. So this is also what I want to underline. This is a long-term problem. I started my career in this area in the open drug scenes in Europe, like here in Zurich in 1990. And the situation since then is getting more complicated because of shifting drug markets and then change in the patterns of use. So now heroin is an exception, as it was used here by these Swiss kids, and fentanyl is the drug of choice. it is highly more potent and highly more dangerous in terms of the consequences. And this is what we experience and see with the number I already mentioned. 6 people are dying every day. And this is an unacceptable situation. And it is worse than the HIV crisis. It's worse than all the public health crises and overdose crises we were seeing. And the current critical situation in, for instance, in the area of homelessness and marginalization of a lot of people is contributing to a very high level of concerns across the board. So looking into the entanglement of self-harm and suicide and other experiences. I mentioned these numbers and I repeat them because it's so important to understand this is not just an accident. This is a development which is visible and understandable over years before things are becoming critical. So if you look at this table, that was a study I did in Germany, comparing a group of heroin addicts and a representative sample of young people. And what you see is there, even before heroin addicts became heroin addicts, they had to go through the separation or divorce of their parents 3 times more often. They experienced the death of mother or father 3 times more often as in the average population. They had an own severe illness significantly more often, and they had the wish not to live anymore 3 times more often. If you look at these numbers, then you see that a lot of the problems, whatever is causing them, were visible already in their childhood. And there is something we could have done much earlier, and we are not doing it. We are not really alert, and we are not really actively pursuing preventative measures or try to intervene supportive to create a stable environment for these children. The same is if you use the construct of adverse childhood events, and among intravenous drug users, so you find the highest level of adverse childhood events as measured by the ACE score, 4 times higher than for other kids. I mentioned the situation for First Nation people. It's dramatic that in this part of the CEDAR study, nearly 50% reported sexual abuse. 2/3 of them were female, and the mean age, of first abuse was 6 years. Aboriginal children, who are 9% of the overall population, but are representing nearly 50% of the foster care population, and about 42% of the youth in custody, so it's 10 times more as their share in the population, was in custody. So the chance to end up in prison, to end up in foster care, to be traumatized, sexual abuse, and so on, is significantly higher. Important to mention is just one physical health issue, which is pain, because it's so close to pain medication and to opioid use. 60% are mentioning chronic severe pain, and mentioned that as a reason to use opiates in the first place. So what does that mean for the system of care, especially after nearly 8 years of experience of a deteriorating rate of mortality? So what do we need to consider to make the system more efficient? So going back to the functionalities, you need to understand the functionalities. So for instance, if users are suffering withdrawal symptoms on an ongoing basis because their supply is not available, or for other reasons, or they want to stop, then the consequence is very often that they kick back to, for instance, street fentanyl use and using on a lower tolerance of opiates and are exposed to a much higher risk. Also, being traumatized is a very strong reason to try to end and address emotional pain. And being suicidal is very often causing a situation to expose yourself to risk, playing with your life. So there is a lot of things are going on there, and this needs to be addressed, not just with any formal harm reduction measures. It needs to be addressed through the interactional power of psychotherapeutic and psychosocial interventions, safe and stable housing, and framework and environment which is protecting these people. So it's coming up to a balance which right now is clearly into the direction of mortality within an ineffective system of care, with treatment silos, changing drug markets, and an inappropriate model of high-risk substance use. That said, what should be in the focus of the construction of the system of care? One is you need to start far earlier than crisis. You need to provide for the high-risk population a targeted prevention effort, access to counseling and care, and you need to start to help with lifestyle development around substance use. If something goes really sideways and risk factors are overwhelming the individuals, you need to intervene early in an early detection, early intervention approach, which is approved and it is effective and it is exercised in the treatment of psychosis. There is no reason to do it in this population which has by far the highest mortality rate among mental illness. And you need an integrated crisis management to address also the social factors, the housing situation and others, to stabilize their life environment. Okay, that means that you need to provide prevention to the majority of kids. You need to be prepared to have early intervention and detection options for at least 10% of the population, and 1% who are overdosing and high risk. They need to have easy access to care, and if they overdose and survive, there needs to be immediately a system which is addressing their needs and helping them to recover. Okay, early intervention is well defined. We don't have a system like that, but it would be helpful to respond before the crisis hits. Integrated overdose response, as I said, and to repeat it again, is a window of engagement. Personal commitment is needed, not just detox. They need to be offered all potentially helpful measures they would like to experience, including stabilization in the housing situation, including OAT treatment, and anything which could happen in the community. If you're not responding, the chance that they're not becoming older than 25 is high. That will definitely not the last overdose they experience. And one key point in that, and we discuss this in this framework a lot, is an appropriate treatment with substitution treatment for adolescent and young adults. The key is to engage them. If we are able to establish a contact, create a framework around them, then this could be a way to have them not only to survive, but also to get much better. Unfortunately, it's rarely used for ideological reason, and the most patients, interestingly, are not in treatment at all. So I mentioned in the beginning the housing situation. They need a milieu which could help them to stabilize, where they would have a place also to be engaged by psychosocial interventions, by peer counseling, by overall supportive environment. And the housing programs to a large degree, some, not all, are providing this support, especially if they closely integrated and connected to the healthcare system. Rooms like this are not a place to recover, and they are in the middle of our town. This is a shame for everybody. So I mentioned in the beginning the data and the publications from the US that less than 10% of overdose survivors among youth end up in care. We need to make sure that nobody, especially nobody after the first survived overdose, is nobody is ending up without support. For that, we need some core components, as I mentioned before. Overall, change is needed. We need a comprehensive therapeutic system of care, of high-risk substance use, as well as the concurrent conditions coming with it. This is a level of attention needed as, let's say, a patient with cancer or a patient on an intensive care unit. It is not a game. It is one of the most serious situations, which is, from my perspective, unfortunately not really understood in its full extent. And innovation needs to be outcome-oriented. So we need to improve access, build more capacity, and really start the conversation about quality of care. Just throwing something a few people think is good is not good enough. We need to approach that as carefully as we approach treatment approaches during COVID or during cancer or other things, in a thorough, careful, and evidence-driven way. Otherwise, we will fail bitterly, like we do right now. I hope that is giving us enough motivation to start a conversation, reach out to each other, create synergy. A siloed system of care is a bad environment. We need to join forces across disciplines, and every discipline, every part of the system needs to address its part, needs to reach out, and we are nobody is able to hide in this situation. Infights and siloism are the worst. So this is not going away, and unfortunately, it will be most likely also a situation happening in other countries across the globe. Just do nothing, because it's so complicated, is the wrong perspective. If you start doing things, nothing is impossible. Thank you very much for your interest.